Assalamu alaikum wa rahmatullahi wa barakatuh. I am Mustafa Muhammad Saeed AlShawaf, and today with Shurooq ElShaeir we will present to you the urinary system PAC session. So first of all, for your urinary system chapter, only these parts you will be asked about: the 25.1, 25.2, 25.3, and 25.8 and 9. Okay, so first of all, we will be discussing general functions of the kidneys and the renal system. So the kidneys in our bodies, they do certain functions, some of them being regulating total volume of the blood, of water and therefore blood, and the concentration of solutes in that water, regulating the concentrations of ions in the extracellular fluid as well as the plasma. Long-term acid-base balance, metabolic waste filtration, and foreign substance removal. And there's also a function mentioned in the blood vessel, in the blood chapter. Can you recall it? Take your time to try and recall it. So this function is the production of the EPO or erythropoietin. And also we have the conversion of vitamin D to its active form. And finally, carrying out gluconeogenesis during prolonged fasting. Okay, so the kidney has three distinct regions that we will be discussing, and a rich blood supply coming from renal arteries and the aorta. And you will be knowing the path of this of these blood vessels, arteries and veins. Okay, so first of all, we will start with the location and the external anatomy of the kidneys. So first of all, it's bean-shaped. The medial wall is concave inwards and the lateral wall is convex outwards. And it's positioned in a retroperitoneal position. That means it's between the dorsal body wall and the parietal peritoneum. It's also in location in regards to the spine. It's in the superior lumbar region, as in T12 to L3. The right kidney is slightly lower than the left kidney due to the liver displacing it. And on the medial aspect of the kidney, we have a vertical cleft called the renal hilum. It leads into the renal sinus, or to the area inside the kidney. Inside the renal hilum enters the ureter, blood vessels, lymphatics, and nerves, all from the renal hilum. And now also another something to recall from the endocrine chapter. What is atop each kidney? Atop each kidney would be the adrenal glands. Okay, now we have three layers surrounding the kidneys of connective tissue and supportive tissue. First of all, from most superficial to most deep is the renal fascia. Renal fascia is dense fibrous connective tissue that surrounds the kidney tightly along with the adrenal gland. So it's surrounding the kidney with the adrenal gland atop of it. And we also have the perirenal fat capsule. It's adipose tissue that's found around the kidneys. It provides cushioning against trauma and movements. And it surrounds the kidney and also the adrenal gland. And finally, we have the fibrous capsule. The fibrous capsule is tightly related to the kidney. It also even dips into the renal sinuses. And And also, here is a homeostatic imbalance. The upper parts of both kidneys are protected by the thoracic cage because it's in the T12, so a part of the thoracic cage is protecting them. But in the lower regions of the kidney, it's not well protected. Therefore, common trauma could happen there. And a sign of that could be hematuria. Okay, so here is a question. During a life-saving operation, the surgeon notices that the right kidney is slightly lower than the left kidney. Why is that the case? So the first option, due to the presence of the pancreas, it's false. This is because the pancreas is very far away from the kidneys. B, because the liver occupies the space above it. This is true because the liver is a bulky organ. It also displaces the diaphragm on the right aspect, and this is why the right lung, if you can recall from the respiratory chapter, why the right lung is slightly shorter than the left one. And also, it's due to the position of the spleen, it's wrong because of the greater length of the right renal artery. This has nothing to do with this. Okay. Okay. A 51-year-old male patient presents with renal calculi or renal stones obstructing the ureter at the renal ileum. Which supportive tissue is most likely affected? So if we go back to the three supportive tissue, the renal fascia, fibrous capsule, and the perirenal fat capsule, which of these is the one that's most related to the kidney? It would be the fibrous capsule. This one is tightly related to it. Other ones would not be affected because, as we said earlier, at the renal ileum, the ureter enters, so the ureter is the closest to the fibrous capsule and not the renal sinus. So the perirenal fat capsule or the renal fascia would not be affected. Another question, a 42-year-old male presents with a large retroperitoneal hematoma following a blunt abdominal trauma. Imaging reveals that both kidneys and adrenal glands are displaced together within the hematoma. Which structure is most likely torn, allowing both organs to move as a single unit? So for these questions, what structure is fibrous? So it keeps the two together, but in this case it's torn, so both move together as one unit. So in this question, it's not the fibrous capsule because this only surrounds the kidney. Perirenal fat capsule is not a dense fibrous tissue in the first place. A visceral peritoneum, it's not even related to the kidneys. And finally, the renal fascia. Renal fascia is the correct answer, as it surrounds both the kidney and the adrenal glands. A 45-year-old construction worker falls from a height and lands on his lower back. He complains of severe flank pain, and imaging reveals a renal contusion with no major vascular injury. What structure primarily helped absorb the impact and protected the kidney from the severe mechanical trauma? In this case, as we discussed earlier, it would be the perirenal fat capsule, because adipocytes in this case help with absorption of the shock. Okay. Now we move on to the internal anatomy. So first of all, we have three major areas here. We have these pyramid-shaped called the renal medullas. They're pyramidal, so sometimes they're also called renal pyramids or medullary pyramids. We also have these between them. They are called renal columns, and finally this area is the renal cortex. Cortex means the outer parts. Okay. So the medulla has a reddish brown appearance. It also has cone-shaped appearance or the pyramid appearance. At the apex of each pyramid, there exists a papilla. Now we will talk about what each papilla feeds into. And we have also the cortex. It has a granular and light-colored appearance. Let me see. And also the pyramids, they appear stripped, like if you look at this image here, they appear to have small line because they are almost entirely composed of parallel bundles of microscopic urine collecting tubules. I guess, yeah, that's it. Also, yeah, there is approximately each pyramid constitute a lobe of the kidney. So there is approximately in each kidney 8 lobes. Okay, now for the blood and nerve supply. This is the kidney. First of all, we have coming out from the heart is the aorta. Then the aorta feeds into the renal artery. Renal artery gives off segmental arteries. The segmental arteries give off several interlobar arteries, then several arcuate arteries, and finally cortical arteries, radiate arteries. This might be a little bit hard to memorize. So we have this amazing mnemonic, a really smart, intern, always connect arteries. So A is corresponding for the aorta, R corresponds for the renal artery, smart for segmental, I for interlobar, always for arcuate, C for cortical radiate, and A for the afferent arteriole. So, and also one thing to mention about the arcuate artery, it's found at the junction between the medullary pyramid and the cortex. This is why it's called the arcuate. The arcuate also has another name, which is the interlobular artery. Yeah, that's it, I guess. Okay, for the nerve supply, we have something called the renal plexus. It's a variable network of autonomic nerve fibers and ganglia. The renal plexus is largely supplied by sympathetic fibers. I don't think this detail is important, to be honest. This is important as it regulates the urine formation by adjusting the diameter of renal arterioles, as mentioned before. Okay, so here is another question. A 60-year-old patient with chronic hypertension develops acute kidney injury. A renal biopsy reveals ischemic changes primarily affecting the renal cortex. Which artery is most directly responsible for supplying blood to this region? So what artery is supplying blood to the renal cortex? So let's discuss the options. The interlobar arteries, they would be between the lobes, as the name suggests, the lobes of the kidney. So no. Arcuate arteries, they would be between it's a good contender for the answer, but it's not the case. They are found at the junction between the medulla and the cortex. And renal arteries, they enter the kidney at the ileum, so they're also not the answer. And finally, interlobular arteries is the correct answer. This is also another name, as we mentioned before, for the choriana radiate arteries. Okay, now we arrived at the 25.2 lecture. Listen. Nephrons are the functional unit of the kidney. So in this lesson, we will be discussing the nephrons and their types and what cells are they made of and their structure. So first of all, nephrons are the structural and functional units of the kidney. So each nephron forms a filtrate that would be later called urine. Okay? This filtrate is cell and protein free. Nephrons empty their filtrate into collecting ducts. So we have collecting ducts that collect from many nephrons. Okay? And each nephron consists of a renal corpuscle and a renal tubule. So this is a renal corpuscle, this circular structure. And renal tubule is this structure that goes here and forms many structures that we will later discuss. All renal corpuscles are located in the renal cortex, while tubules begin in the cortex and then pass into the medulla before returning to the cortex. So we will be discussing this specific line later. Okay, so another thing to recall from the blood vessels chapter. What type of capillaries is the glomerulus made of? So the epithelium that the glomerular capillaries are made of would be fenestrated capillaries. This is to help with filtration. Okay, so now we will be discussing the renal corpuscle. So we have a glomerular capsule that has so the glomerular capsule has two layers, the external and an internal layer. External would be called parietal and the internal would be visceral, just like what we do with the perosteum, with the peroniums, right? Okay, so coming to nephrons, wasn't this slide, was it? Oh, it was this slide, yeah. So nephrons have two layers, the parietal layer and the visceral layers, or the external parietal layer and the internal visceral layer. Both layers form the glomerular capsule. So we have the glomerulus and the glomerular capsule like this above it. Okay. The parietal layer is composed of simple squamous epithelia, and the visceral layer consists of podocytes. These podocytes are epithelium cells that are modified with, like as the name suggests, podocytes, so food processes that basically form filtration slits like this. So this is a podocyte. This is the foot of a podocyte, and also forms like these little spaces called filtration slits. So the filtration slits, they form our initial urine, or what's called as a filtrate. Okay, in the capsular space. So between the visceral and parietal layers, we have our filtrate formation. This is where our first filtrate forms. Yeah. Here is a question. A 12-year-old boy presents with generalized body swelling and frothy urine. Urinalysis reveals massive proteinuria and hypoalbuminemia. A renal biopsy shows effacement of podocytes food processes on electron microscopy. Which specific part of the renal corpuscle is primarily affected in this condition? So the glomerulus, it doesn't relate to the podocytes, as in it's not part of the glomerular capsule. The glomerular capsule is a generalized option, so it is affected, yes, but it's not the most precise answer. We have the visceral layer, which is the correct answer because the podocytes form the visceral layer, and the parietal layer is false because it's composed of simple epithelia. Okay, we have the renal tubule and collecting ducts. So each, as we mentioned before, glomerular capsule feeds into renal tubules and collecting ducts. So first of all, we have a renal tubule that forms a proximal convoluted tube, a nephron loop, or also called loop of Henle, and a DCT, or a distal convoluted tubule. So as the name suggests, proximal convoluted tubule. So this is our renal corpuscle. Here forms the filtrate. It goes, then forms convoluted, so it forms like a network with the tubule, and goes down as the nephron loop, and then goes back up again and forms another convolution or network called the DCT, or the distal convoluted tubule. Okay, so the entire length of the renal tubule is about 3 centimeters. The filtrate, as the name suggests, first passes from the PCT and then to the DCT. So they are named PCT, proximal, and the distal in relation to the renal corpuscle, which one is more proximal to it and which one is more distal to it. This here is an image showing the, where is it? The glomerular capsule, the parietal layer of the glomerular capsule, and the podocytes of the visceral layer. Here is the cells found in the proximal convoluted tubules. Their epithelium, they're cuboidal. They have a lot of mitochondria. They have a lot of microvilli forming a brush border-like for reabsorption mainly. So it plays a major role in reabsorption of water and solutes. And for the distal convoluted tubule, it has also a lot of mitochondria, but not as much as the proximal convoluted tubule cells. It also has some microvilli, but not as much. And finally, for the nephron loop, it has 2 segments. So we have a thin and a thick segment. The thin segment does look like this. It's mainly made of simple squamous, and the thick segment is mainly cuboidal. And for the thick segment, it could be in relation to one of 2 things, either to the proximal convoluted tubule or the distal convoluted tubule. If it was in relation to the PCT, it would have a histological appearance similar to that of the PCT. And if it was related to the DCT, it would have a histological appearance similar to that of the DCT. Okay, we also have 2 types of cells that we'll be discussing in the next slide: a principal cell and the intercalated cells. The intercalated cells, they have microvilli, and the principal cells, they also do, but not as much. Okay, so for the collecting tubule, it consists of 2 types. So after the DCT, the filtrate goes into the collecting duct. Okay, the collecting duct has 2 types of cells: principal cells and intercalated cells. Principal cells have sparse microvilli, and they are mainly responsible for the water and sodium balance. And for the intercalated cells, we have 2 types of them. We have A and B, and therefore, it's as a way to memorize them. A and B, therefore, acid-base balance. So A acid, B base balance. Okay, it's not, it's not related as in type A is for acid, type B is for base. No, it's not like this. It's just a way to memorize it. Okay, so yeah, this is mainly the difference. Each duct receives filtrate from many nephrons. These ducts run parallel to each other in the medullary pyramids. So we mentioned before that the medullary pyramids have like stripped appearance. This is because of the collecting ducts. Okay, and here's something to think about. When would the filtrate be called urine? So the existence of these types of cells denotes that the filtrate is still modified here in the PCT, in the DCT, even in the collecting duct. So when does this filtrate stop being edited? When does it خلاص it's in the final form and now can be called urine? So if we go back to here, to the renal pelvis and the renal sinus and this is the ureter that goes into the bladder, okay? And the ureter collects urine from where? From the renal pelvis. The renal pelvis has 2 to 3 major calyces, and each major calyce is fed by many minor calyces, and each minor calyce is fed by one medullary pyramid. Okay, so the moment the filtrate enters the minor calyces, its name is changed to the urine, so it stops being filtrate. Okay, now we also have 2 types of nephrons. We have cortical, as the name suggests, they're found in the cortex of the kidney, and juxtamedullary, also as the name suggests, juxta meaning near, and medullary referencing the medulla. So they originate close to the cortex medullary junction. They play a role in the formation of concentrated urine, and they have long nephron loops that deeply invade the medulla. And this is also called the vasa recta. We will mention the function of the vasa recta later. Also, most of the kidney, 85% of the nephrons in the kidney, they are cortical, and the rest are juxtamedullary. Okay, so here is something to discuss. Okay, so moving on to nephron capillary beds. So before we start, let's recall from the blood vessels chapter what usually enters and what usually leaves a capillary bed. So we usually have an arteriole going into the capillary bed and the venule collecting from the other end. Okay? But in the case of the kidneys, in the glomulars, we have afferent arteriole and efferent arterioles. So we have 2 arterioles. And what is the significance of this? Why do we have 2 arterioles? So this is to keep high blood pressures throughout the nephron for the modifications that will occur later to the filtrate. Okay, so every nephron is associated with 2 capillary beds. The glomulus, the one special one that has 2 arterioles, one afferent and efferent, and a combination of peritubular and vasa capillaries. Okay. The glomuli are specialized for filtration and filtrate formation. So filtrate formation occurs in the glomuli or glomerular capsule. And another thing to recall, from what arteries do the afferent arterioles originate from? So most nephrons, as we discussed before, are found in the cortex. And in the cortex, what arteries are the main ones feeding there are the corona radiata, or the interlobular arteries. So the interlobular arteries are the ones that feed into the afferent arterioles. Okay. Here's a table comparing both the peritubular capillaries and the vasa capillaries. So they both originate from afferent arterioles, but one originates from cortical nephrons and the other from the cortical nephrons and the other from the juxtamedullary nephrons. Vasa recta is solely associated only with the juxtamedullary nephrons. Okay. So for the structure, the peritubular capillaries, they are meandering, means they're thick or of different thickness. They are branching and cling to the tubules. For the vasa recta, they are thin, straight, and run parallel to the nephron loops. And for the location, they are found peritubular, they are found in the renal cortex, and the vasa recta, they are found in the renal medulla. And this also explains the appearance of the renal medulla, why it's striped. And finally, for the blood pressure, they are both relatively low blood pressure compared to the original afferent arterioles. And finally, for the functions, the peritubular, they absorb substances from multiple adjacent nephrons. So one peritubular capillary could be absorbing from many nephrons together. Okay. And for the vasorecta, they supply oxygen and the nutrients to the renal medulla. They also play a major role in the formation of concentrated urine. So, what is the function of renal? Can you tell me what's the function of renal?
Renal increases blood pressure indirectly by increasing, first of all, sodium and then taking water with it into the blood vessels.
That's correct. So, renal increases blood pressure via increasing sodium. This is a shortcut. This is not the entire story. You took the entire story before, I believe, in the blood vessels chapter. Okay, so why are we mentioning renal? So we will discover just now. So in the juxtaglomeralar complex, the juxtaglomeralar complex is a modification of cells that occurs in the distal region of the ascending limb. So what does that mean? So before the DCT forms, the ascending part of the nephron loop forms this complex, the juxtaglomerular complex. And this touches the afferent arteriole and forms this complex. So what is this complex? What it is made of? It's made of three types of cells. One type is found within the ascending limb. One type found in between, and the last part is the granular cells, or the one that's found in the afferent arteriole. Okay. So what does this mean? So let's discuss it. So first of all, we'll start with the macula densa cells. These are the cells that form part of the ascending limb. They are tall, they're closely packed together. They have chemoreceptors to monitor the sodium chloride content of the filtrate entering the DCT, because they're just formed for the DCT. And we have granular cells, or also called juxtaglomerular cells. They are enlarged smooth muscles that have mechanoreceptors to sense blood pressure, and they contain granules that secrete renin. So the renin that was discussed before in the blood vessels chapter, this is it. It comes from here, from the granular cells. Okay, and finally we have between these two cells the extraglobbular mesangial cells. Extraglobbular mesangial cells, as the name suggests, extra meaning outside. So yeah, they're between. They lie between the arteriole and the tubule cells. They are interconnected by gap junctions. So gap junctions here is a very important keyword. They also pass regularity signals between the macula densa and the granular cells. So they communicate both. Okay. So one thing also to differentiate between the macula densa and granular cells, macula densa they have chemoreceptors, while granular cells have mechanoreceptors. Okay. So moving on to my question. A 13-year-old boy comes presenting with renal calculi in the emergency room. Which of the following cells is responsible for the sodium balance in his kidneys? So we have two types, we'll be discussing them. First of all, we have intercalated A cells and intercalated B cells. We can disregard both options because intercalated A and B cells are responsible for the acid-base balance. Okay. And the granular cells, they are the ones that secrete renin. And finally, the answer should be the principal cells. And طبعا ignore this, it should be T. Okay. And now we have matching questions. So let's try to connect them. First of all, peritubular capillaries. They cling closely to adjacent renal tubules and empty into nearby venules. This one suggests. Then we have vasorecta. Vasorecta are they play important role in the formation of concentrated urine, and they also are bundles of long straight vessels serving the juxtamedullary nephrons. Okay. Here the afferent arteriole it's flat, it doesn't connect to anything. And finally the cortical nephrons, they account for most of the nephrons found in the cortex or in the kidney generally. Okay, here are the answers. And this is the final part of the chapter, overview of filtration, absorption, and secretion. So we have three processes in the kidneys. We have glomerular filtration, the one that we mentioned before, the glomerulus and the glomerular capsule. This is where the filtration occurs. And we have tubular secretion and reabsorption. These two processes, they occur along the tubule. So here, Okay. So the glomerular filtration takes place in the renal corpuscle and produces a cell-free and protein-free filtrate. The tubular reabsorption, as the name suggests, selectively reabsorbs moving substances from the filtrate to the blood vessels. It takes place in the renal tubule and collecting ducts. It's, by the way, the same location for the tubular secretion. For the tubular secretion, it's selectively moving substances from the blood into the filtrate. So it's the opposite of reabsorption. Glomerular filtration is a passive process. Tubular reabsorption and secretion are both active processes that require energy. And finally, let's have a quick discussion of filtrate versus urine. So filtrate is our initial product, and urine is the final product. Filtrate is first formed in the renal corpuscle, and urine is first formed in the myocardices. Okay. So let's have some numbers just for your knowledge. About 1.2 liters of blood pass through the glomeruli each minute, and about 100 to 125 milliliters of plasma passes through the glomerular capsule. So that daily it's about 100 liters of filtrate. And of that 180 liters of filtrate, only 1.5 leaves the body as urine. So most of it is reabsorbed. So things that are reabsorbed could be generally like glucose, amino acids, and other, and the 99% of the water. And yeah, that's it, I guess. And also, I want to touch back on the topic. Yes, yeah. So I forgot to talk about the veins initially. For the veins, they're the same as the arteries, except the same but in reverse order, except we don't have segmental arteries, segmental veins. Sorry. So it's caudate veins, acute veins, interlobar, renal, and inferior vena cava. So instead of the aorta, we have inferior vena cava. And yes, this is it. Thank you all, and now we'll be moving to my colleague Shurooq.
All right, so hello everyone, salam alaikum. Welcome to the second part of this renal review session. My name is Shurooq AlShawaf. I'm a year 2 medical student. Some of you may know me, some of you may not. If you don't, hello. I am happy that I'm going to be able to help Foundation in one way or another. This year holds a special place in my heart. Inshallah, all of you got this. استعينوا بالله وبالصبر والصلاة وعملوا اللي عليكم إن شاء الله خير. All right. So I'm assuming by now my colleague Mustafa has explained the anatomical part of the kidneys. Now here's the deal. In this chapter, it jumps from this anatomical part to these two lessons right here. And that's a big jump because all the cancelled aspects of this of this chapter include the physiology of it. Now, why am I saying this? It's because what do these two lessons want from you? They want you to be able to evaluate renal function, to know the urine composition, to know the anatomy and physiology of the ureter, bladder, and urethra, and the physiology of micturition. Now, I'm saying that's a big jump because for you to evaluate renal function, you must understand it, all right? So briefly, I'm going to very, very briefly go over the functions of the kidney. My colleague Aslan may have gone over them, but I'll just reiterate them for the sake of my part, okay? The kidney, my friends, is a very, very, very picky landlord. Okay, very picky person, and is very specific about who stays in the body and who goes. So that's basically its function, right? It filters the blood because, again, not everything in our blood should stay in the body. Some things get reabsorbed because we need to have it in the body, and some are secreted, are kicked out, right? Now, one might ask, okay, but what's the difference between filtration and secretion? Filtration is a passive process and it depends entirely on what's happening here. So unfiltered blood goes into the glomerulus and purely through hydrostatic pressures, things go out of the capillaries and you have your filtrate. So it doesn't need any extra energy. It doesn't need any extra, work, if you like, between quotations, work. So it's just what gets filtered. Passive process, blood moves into the glomerulus and stuff comes out into the Bowman's capsule like a giant kitchen strainer, right? It happens passively. On the other hand, secretion is an active process. So it's basically the body and the kidney saying, you know what, this specific substance I don't want in my body. So not only am I going to filter it, I'm going to actively kick more of it out than what is usually filtered. Like throwing extra trash into the bin manually, okay? And looking at this beautiful diagram here, you can see our kidneys, the renal artery, renal vein. And then I also want to just have you look here. This is the loop of Henle, of course. And you see these capillaries next to the loop of Henle are called the peritubular capillaries. And this is where the secretion happens. So it's, let's go here, right? Again, unfiltered blood goes in here. Filtrate gets filtered into the Bowman's capsule and goes into the rest of the tubules. And then the filtered blood, right, goes into these peritubular capillaries. You see, we can follow it all the way here. And whatever is left here that we don't want gets secreted into these tubules or into the loop of Henle. All right? So just a couple of examples of things that are reabsorbed. Glucose is a big one, right? Glucose, as you probably already know, is a very important molecule in our body, and it gives us energy, and it gives very specific organs energy as well, like the brain, like red blood cells and stuff like that. So glucose is actually one of the things that is 100% reabsorbed. The body does not mess with its glucose, my friends. It has to reabsorb every single one. In fact, if you ever read the clinical scenario and it says glucosuria, which means there's glucose in the urine, this is abnormal. That means there's something going wrong, okay? Another example, but for secretion, is H+. It is actively kicked out, all right? So these are just two examples. Sorry for any background noise. But these are just two examples that you can keep in mind. Again, I don't think you have to memorize them. It's just for the sake of understanding. A lot of the things that I'm talking about right now is for the sake of understanding what's in those two lessons, right? You don't have to memorize them. Again, don't panic. This is not asked of you. But it's a very beautiful diagram if you actually understand what's going on. Like, it's showing you the amount of NaCl, potassium, water, because at each part, they are absorbed or secreted differently, and different hormones act on different aspects of the tubule, and it's just subhanallah, and it's amazing, the incredible detail. All right, so let's go into my first analogy. As you can tell, I am very much a Potterhead. I hope some of you are too. Basically, I'm going to use Harry Potter as a bit of an analogy for you to understand this process, right? So in the world, generally, you have a mix of everyone, yeah, right? You had muggles, or اللي هم non-magic people, يعني, for those who have never watched Harry Potter, and normal people. And the reason why I'm saying this is because this is like the blood, right? The blood includes everything. It includes your red blood cells, includes your white blood cells, platelets, it includes electrolytes, proteins, toxins that need to be excreted, right? So it's the pot, it's just the general everything. So what happens is at the glomerulus, the sorting hat, which is our kidney, decides who is magic enough to go into the exciting journey that is the tubules and the loops of Henle والحاجات الجميلة دي, and who is muggle-born and stays outside. So an example of the muggle-born people is red blood cells, right? Blood cells in general are not supposed to be filtered into a Bowman's capsule. So this is an example of them staying out. But those who are things that are filtered, things like glucose, which will then later be absorbed, sodium, potassium, the works, right? And their fates are three things, just like how the sorting hat sorts the magic little molecules into houses, right? And the Gryffindor, right? It represents reabsorption. Gryffindor is known notoriously to being a good house. Like, they're brave, they're amazing. So we want to keep these Gryffindor molecules in the blood. And you can remember it because Gryffindor is a red house, right? So remember, blood and red, because we are reabsorbing it back. Where? Here. See? They go back into the blood. It works both ways, right? See? Reabsorption and secretion. See? Like here. It's very clear, and it's going into the ducts. Creatinine, these stuff are secreted, and those stuff are reabsorbed, okay? So Gryffindor, again, our brave, amazing house, that's in red. It represents the good molecules that I want reabsorbed back into my bloodstream. Hufflepuffs are cuties, very يعني مسالمين جدا. They represent the normal filtered products that go into the Bowman's capsule and get excreted normally. And you can even see Hufflepuffs are yellow, which is the color of urine. Right, filtered products, they go passively outside and they don't cause any trouble. And then we have our troubled people. So sorry if any of you are Slytherins. But things that we want secreted out of the body. Like Slytherins are known to be sneaky and evil and we don't want them. I'm very sorry. But so they are represented, or secreted products are represented by Slytherins. And you can remember green, it's the only odd color out of all of them, right? And I am purposefully getting them from this blood capillary over here, particular capillary, and putting it back into the tubule. So this is just a bit of an analogy, right? Again, let me repeat. The world is like a blood cell, right? Sorry, like a blood capillary, and it includes everyone, Muggleborns and magic people. So in renal terms, they include everything from blood cells, from electrolytes, from proteins, yada, yada, yada. And then we come to the kidney, which is our sorting hat that separates those two things. And then our magic little molecules get sorted into these three houses, depending on, طبعا, this depends on a lot of things. It could depend on the charge of the molecule, could depend on the size of the molecule, but most probably I would like it associated with the needs of the body. So good molecules that we want to keep are sorted into Gryffindor and they go back into the blood cell. Molecules that we want excreted normally, they don't cause any trouble, but it's just time for them to leave. It's Hufflepuffs and they are excreted yellow. And then our evil little molecules, please, between quotations, yani evil, they get secreted out. Okay? So it's just a fun way for you guys to understand, because then we're going to move on to GFR and renal clearance. What is GFR, right? GFR stands for glomerular filtration rate. So first, think of GFR like a truckload of blood is arriving at the nephron gates, or at the nephron in general, every minute, right? A truckload of blood. And if you want to be a bit specific even, it's 1.2 to 1.3 liters of blood a minute. 20 to 25% of your cardiac output goes to the kidneys. It's crazy. So this amount shows up at the kidney, at the nephron, every minute. But as we said, our kidneys are picky because they have to be, right? They're responsible for keeping people in or kicking people out. So why am I saying this? Is because these 1.2 to 1.3 liters of blood, طبعا we know that blood is not all of it can get filtered. What actually gets filtered is the plasma, and we know that plasma is 55% of blood. So 55% of this is about 715 milliliters of plasma. So 715 milliliters of plasma, again, show up at our trusty nephron each minute. Again, our kidneys are picky. They can't be specific and peculiar enough if they're filtering 715 milliliters of plasma a minute. So what does it do? It takes only 125 milliliters to filter at a time. Okay? So only 125 milliliters of plasma per minute gets filtered, and that is the GFR, the glomerular filtration rate. So at the glomerulus, try to say that 3 times fast, we filter 125 milliliters per minute. That is the rate. So it's basically me asking, how good is the kidney at filtering right now? Because again, if this number is too low, that means I am moving too slow and toxins will build up, and we'll talk about that. And if it's too high, that means I'm not being picky enough and some things may be left behind that again can cause issues. So the sweet spot is 125 milliliters per minute, okay? And crazily enough, GFR, as I said, remember up here, I said filtration is a passive process, and that is because GFR is almost based entirely on pressures. Again, you don't need to know this. This is just for your understanding. But if you look at this blood vessel right here, right, the renal artery, it's bringing in unfiltered blood. And طبعا this is coming in with a specific pressure. Let's recap back to the blood vessel chapter a bit. We have two kinds of pressure, hydrostatic pressure and colloid osmotic pressure, or otherwise known as oncotic pressure. And it's this pressure that pushes these filtered substances out. That's why I said it's a passive process, because we don't use energy. It's just built in. And طبعا, let's say for a minute, this blood is coming in, صح? And we filtered out sodium, we filtered out potassium, we filtered out urea, creatinine, whatever. What stays here are the big molecules that don't get filtered, like cells. And very, very important, what is the main thing for colloid osmotic pressure? Albumin. Yes. So albumin stays طبعا. It's not supposed to go in there. Remember, big proteins like that are not supposed to be excreted. They're not supposed to be filtered أصلا. And again, if you see any clinical scenario with a lot of albumin in the urine, that is abnormal, okay? That means there's a problem at this establishment right here. Again, this is all for your understanding. So albumin is responsible for taking some of that fluid back. Again, our body loves balance, subhanallah. We always love to be balanced. So as much as this pressure is driving things out, we need to get some stuff back in, okay? Otherwise, we're going to keep losing more than we intend to. So this is just a brief explanation of what GFR is. It's the amount that the kidney is filtering and rummaging through per minute, and that is 125, and it's based entirely on hydrostatic pressures. Now, clearance, right? So what's clearance, okay? Clearance is basically the rate at which a substance is completely cleared from the plasma by the kidneys per minute. This is telling us how well the nephron cleared something compared to how much was in the blood to begin with, which is why this formula has a bunch of really variables that make sense. Look, U represents the concentration of substance in the urine, and P represents the concentration of substance in the plasma, and V is the urine flow rate. For me to know how good or how well the nephron cleared something, I have to compare it with the amount that's in the plasma and the amount that has come out in the urine, and طبعا taking into account how fast I'm making urine, okay? And so that's basically what renal clearance is. All right, let us continue. So that's what renal clearance is. So how are these two linked? GFR is kind of like the maximum potential filter rate. And clearance tells you how efficiently you're actually getting rid of a specific substance, either by filtering it, secreting it, reabsorbing it, all right? Now, what am I talking about when I talk about inulin right here? Inulin, right, is this amazing substance that its clearance is equal to GFR because it's only filtered. It's not secreted or reabsorbed. So this tells us something very important. Let's go right here, right? So basically, let's go back here. So basically we said GFR is 125 milliliters per minute. That means inulin gets cleared out in the same way. So we clear out 125 of it, like of this substance per minute, right? And again, this goes back to it being only filtered, okay? So if you can see here, this is the clearance rate of inulin, and it's showing you the urine concentration, the urine flow rate, and how much was in the plasma, giving us the same GFR. Now, inulin is really great because we can use this to see the clearance and actually how well the kidney is working. Because if we find something that its clearance is just like inulin, that means it is only filtered, and that's also why we use it. But if I find something that's clearance is less than inulin, for example, if I find something that tells me, like urea, its clearance is 70 milliliters per minute. What does this mean? It means that the kidneys successfully remove the equivalent amount of urea you'd find in 70 milliliters of plasma a minute. So for simplicity, we compare things to inulin because its clearance is 125 milliliters per minute, meaning it occupies every single milliliter in the normal GFR. So when I say something like 70 milliliters per minute, that means that because some of this substance was reabsorbed, it's as if I only cleared 70 milliliters of it, even though I did the normal 125. So when I see something like creatinine and its actually clearance rate is 140, how did I get 140 when 125 is all I can clear? Because it's secreted, right? If you can go back to this diagram here. So again, 125 milliliters are filtered here. So, and they go through all of this amazingness, right? And then they go near these capillaries. And not only does it reach 125, but the capillaries put more of the substance from what they have. It goes up to 140. That's as if I cleared 140 milliliters, but I still did the 125. So again, the normal GFR is 125 milliliters per minute. That means إنه the nephron takes 125 milliliters of plasma to filter a minute. Inulin occupies each one of these milliliters because it is a substance that is only filtered. So the body does not take some of it back and it does not excrete more of it out. You gave him 1 milliliter of inulin, or بلاش 1 milliliter. You gave him 5 milliliters of inulin, it will excrete 5 milliliters of inulin in 1 minute because it only takes this amount to get out. But if I see something with a clearance less than inulin, that means إنه I took some of it back. I didn't. So it's like I only filtered I only filtered 70 milliliters, but I only did 125. Again, to keep it simple, remember inulin is only filtered, فit equals the GFR. If I see something less than that, then know that this substance is reabsorbed because I'm not seeing that amount in the urine or in the blood. In the urine, sorry, because we're comparing it. Remember in the formula we compare the amount that's in the urine to the amount that's in the plasma. So basically, and if I see clearance more than inulin, that means it's secreted. I have added more than what is usually in the 125. So just keep this as a rule in your head. Now, why am I talking about this aslan? Because magically, this would be an amazing substance to measure kidney function with, right? Because GFR is indicative of kidney function. If the kidney is filtering less than 125, that's very bad. And more, that's also very bad. So for me to check, wallah, I give someone inulin and I see how fast they excreted. And if they excreted it within a minute, then the kidneys are amazing. But the inulin is an exogenous substance. And it's also very annoying and impractical clinically because you have to give it through IV, and then you have to monitor the plasma concentration, then you have to monitor the urine concentration. But it's a bit annoying. So what doctors did is, you know what, خلاص, madam, we know the clearance of creatinine, which is a substance already made by the body. This is an endogenous substance. Since we know its clearance rate, فخلاص, this is what is usually used in hospitals to see the kidney function. Since again, they already know its clearance rate, they already know it's a bit secreted, they can tell when kidney function is bad or not, and it doesn't have to hassle the patient. All they have to do is just take one blood sample, wassalamu alaikum. That's it. So again, most of this was just for your understanding. Remember, the basic functions are filtration, reabsorption, and secretion. Filtration is passive, secretion is active. And what the Bowman's capsule does is it filters, again, remember, if you would like, you can remember this analogy. It filters the muggle-borns from the magic. Muggles, like red blood cells, like big structures that should not be filtered. And the magic little kiddos are like electrolytes that should be filtered. And they have 3 fates. Gryffindor, they get reabsorbed. Hufflepuff, they get excreted. And the evil ones, again, sorry, they get secreted into the urine. GFR is how much the kidney is filtering per minute, and the normal amount is 125. Again, this is a passive process based entirely on hydrostatic pressures. Clearance is how well the kidney can get rid of a substance using this rate, right? And a magic compound that we can use to measure GFR to measure clearance is inulin, because it is exactly like GFR. So clearance that is like inulin, that means the substance is only filtered. If you ever see a question with the clearance of something less than inulin, that means it is being reabsorbed. And more than inulin, that means it is being secreted. All right? Now we can move on to the very easy aspects of the chapter, okay? Urine composition, again, very easy, right? It's yellow in color. The darker it is, that means the more concentrated. That means the more dehydrated the patient is. And the lighter, that means could actually hint at overhydration. Like if someone is urinating a very, very pale color of yellow or almost no color, that means they are very well overhydrated, and that should not happen also. Again, we like to be balanced. Should be transparent. Cloudy urine can be a sign of infection. Okay. Slightly aromatic, slightly acidic, and diet can alter this. And one of the things that can also alter it is something called a nasogastric tube, because if you guys know this, it's basically a tube that goes through the nose, into the esophagus, and into the stomach. And it's usually given to patients that for some reason cannot ingest food, right? It could be due to a multitude of reasons, really. They have problems swallowing, they're not keeping food down. It could be a bunch of problems. But yeah, it can cause an infection that can turn it alkaline. Specific gravity. To make this simple, okay, it's how close the urine is to distilled water. Distilled water is 1.0. The closer the specific gravity of urine, the more dilute it is. Because distilled water is pure, يعني it's H2O with no additives, right? It's like boring soup. So it's just water and nothing else. The closer the number is to 1.0, which is distilled water, the more dilute it is. And the further, the more concentrated, right? So yeah, those are basically the urine composition. And we can go through our first homeostatic imbalance. Chronic renal disease. Let's do another color. Let's do yellow. Chronic renal disease. And it's characterized by what? This is very important. Less than 60 milliliters a minute. That's going to be a big problem. You know why? Because that means the kidneys are taking less amounts of plasma to filter. So that means toxins can build up more. And the criteria to diagnose someone with chronic renal disease is they have a GFR of less than 60 milliliters per minute for at least 3 months. At least. Okay? And the big thing you remember here is diabetes. Diabetes messes up almost everything in the body, يعني للأسف. And one of them is the kidneys. It affects the kidneys to a very great extent. And so yeah, remember this for chronic renal disease. It is one of the biggest causes of chronic renal disease. طبعا closely after it is hypertension. Renal failure is the kidney filters less than 15 milliliters per minute. حتى the thing is called uremia, which literally means urine in the blood, because it's not filtering as much as it needs to be. All the toxic substances and all the things that need to be excreted are building up in the blood. It's as if you have the urine in the blood instead of excreting it out. Very important: fatigue, anorexia, muscle cramps, and mental changes. Mental changes because again we are having accumulation of toxins. And very important here is low EPO. Why? If the kidney is being this bad at its job, that means it's also being bad at its other jobs, like making EPO. And what did EPO do? It stimulated red blood cell production. So low EPO, that means this patient is also going to have anemia, right? So this could also be one of the symptoms. And what do we do here? Dialysis or renal transplant, or dialysis while they wait for the renal transplant. But طبعا we have to start filtering the blood, or this could turn very fatal. Again, these numbers are important, at least يعني in my year they were. Okay, so now we can move on to the ureters. The ureters are the tubes or the structures that bring urine from the kidney and into the bladder. Where do they begin? At L2. Okay, they begin at L2, and they are a retroperitoneal structure. What do I mean by that? Look at this beautiful picture right here. Okay, this is a picture of the pelvic area of the abdomen, and this sheet, this very transparent sheet is called the peritoneum. And when I say the ureter, which are these tubes, look at them. These are the ureters right here. A retroperitoneal, as you can see, they are behind this transparent sheet of peritoneum. So that's what I mean by a retroperitoneal structure. يعني it's as if I have, you can imagine someone standing in front of a wall and putting saran wrap on them. The ureters are behind this peritoneum. That's why it's called a retroperitoneal structure. Intramurally oblique. What are these big words? Let's go back here. Again, beautiful photo. So this is the bladder, right? This structure. Let's use the pointer. This structure over here is the bladder. And this tube here is the ureter. If you notice, let's say, this is the bladder, okay? طبعا okay, this is not a bladder. I am not that good at drawing, so just forgive me. Let's say this is the bladder. The ureters, interestingly enough, when they descend, they don't enter هيك at a 90-degree angle. They enter, look at the angle here, obliquely. Look, they're going like this. وعظمة الخالق, يعني subhanallah. Why does this happen? It's because imagine, right, this is the bladder wall, and we're going to talk about it. And it's a very muscular wall. And we're going to talk about the bladder, micturition and urination. But هيك, a small thing, the bladder contracts to urinate. And imagine, طبعا contraction يعني pressure rises. Imagine if this opening, the ureteric orifice, is still open while this pressure increases. So what's going to happen? We increase the risk of urine going back up. Oh, this is a problem. This can cause infections. It can cause a bunch of things that we do not want. So this oblique entrance helps it that when pressure increases in the bladder, like when the bladder contracts, it closes this ureteric orifice. If it kind of goes from a patent tube like this to something like this. It closes it off so that urine does not go back up. So that's what it means by it has an intramurally oblique entrance, so that prevents backflow of urine. Histology is very, very easy. We know, like the usual, right? We have the adventitia, which is the outermost layer. We have the mucosa, which is made up of transitional epithelium and lamina propria. We can look here. Mucosa muscularis adventitia, right? MMA, from in to out, طبعا. And mucosa, you have transitional epithelium. You have, sorry, not the mucosa. We're talking about the muscularis here. Mucosa has transitional epithelium, but I'm talking about the muscularis because there are a couple of things to talk about here. The first muscle that we have is an inner longitudinal muscle, and the second one is an outer circular muscle, and these are present within the entire ureter. But we have a special guest appearance in the lower 1/3, and that is an external longitudinal muscle. Okay, so just keep that in mind. Again, very important to also remember is that we have no submucosa, MMA only. I didn't have any S. Okay. And urine, interestingly enough, how it goes from the kidneys to the bladder through the ureters is not only by gravity. We actually have peristalsis, which are muscular contractions. And it's like when the urine goes in the ureters, it stretches the ureters, but that causes kind of like the peristalsis. It bounces back and moves it along the ureter. All right, we went through that. Bladder, right, the storage center of the urine. It is also erythroperitoneal organ, and you can look here. This is طبعا a female this is a female uterus, a female pelvis. As you can see, this is the uterus here, and this is the bladder. And look at here, see, it's covered by the same peritoneum. Okay, so again, remember the person standing in front of the wall with saran wrap in front of them. So, and it is usually posterior to the pubic symphysis. I feel like this is a bit self-explanatory. This is the pubic symphysis, say. It's a joint between the two pelvic bones. It's directly behind it, posterior, okay? طبعا, this differs in males and females, okay? In males, inferior to the bladder is the prostate. And this is very, 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 very important, okay? Inferior to the bladder neck is the prostate. We can look here. See, this is the bladder neck, or otherwise known as the internal urethral orifice. Okay, and this structure here is the prostate, which is in males. And I'll tell you why it's important in a second. In females, it is anterior to the uterus and to the vagina. Again, you can remember this photo. See, this is the uterus right here. So it's in front of it, right? Anterior to the uterus and posterior to the pubic symphysis. Why was I saying that the prostate is very important to know? Because look, the bladder, it becomes very narrow as it goes down, طبعا. And this prostate here, as men get older, most of them have prostate enlargements. And this causes problems with urination. Because, طبعا, as this prostate will enlarge, then this place will get thinner and thinner. مش thinner and thinner, smaller and smaller, narrower and narrower. So it can get to the point where they cannot urinate effectively. That's very important to know, okay? What else about the bladder? Rugae. Rugae are little, like they look like this, right? They're little squiggly lines. They're not lines, but they're folds. That's the word that I'm looking for. They are folds that give the bladder more surface area so that it can hold more urine. And usually when the bladder is full, these are not seen. But when it's empty, they are seen, okay? Another very interesting structure in the bladder is called the trigone, which is triangle, right? It's this triangular aspect of the bladder. And if you look at this photo, look, you can see the rugae, right? And they're demonstrated by this texture. And then here it's completely smooth. And that is a very important characteristic about the trigone, that it is smooth. Why is it smooth? Because it actually originates from a different place embryologically, but I'm not gonna worry you with that, okay? Then we also talk about the internal urethral orifice, so it's at the end of the bladder, and the external urethral orifice at the end, right here, right? It's usually, that's the external urethral orifice, internal and external. So again, the bladder is the storage center. It is made up of muscle. It's made up of muscle, the truther muscle to be specific. In males, you have the prostate inferior to the bladder neck, and in females, the bladder is in front of the uterus and the vagina. And what else can we talk about? Rugae, very important for surface area. And the only place in the bladder that does not have this rugae and is smooth is the trigone. And it's actually very susceptible to infections, right? Usually, if a bladder is infected, this is the place, okay? Usually. All right. So I believe we can move on from here, right? We can move on to the urethra. Simple enough. It's the tube, the muscular tube that carries urine from the bladder to the outside of the body. And let's talk about it histologically, right? So near the bladder, you have transitional epithelium, which makes sense. صح؟ Because أصلا the bladder distends, it stretches and goes back, or stretches and go back. So it transitions through many things. It makes sense in the aspect of the urethra that's close to the bladder would be the same epithelium, right? Near the opening, it turns to stratified squamous because, again, near the opening or any body structure that is, excuse me, that is, bismillah, that is that is interacting with the outside world needs to be made up of strong epithelium that can withstand anything. That's our trusty stratified squamous. And in the middle, that's when it gets its own kind of identity, and it has pseudostratified columnar epithelium. So again, near the bladder, like the bladder, transitional. Near the outside of the body where I can have problems and it needs to withstand a lot of wear and tear, stratified squamous. And in the middle, pseudostratified columnar epithelium. Now would you look at that? Actually, let's talk about it here, differences, because here it's more clear. So let's talk about the sphincters, all right? So in the urethra, you have two sphincters, internal urethral sphincter and external urethral sphincter. How you can see it here. Here, this is the internal sphincter and this is the external sphincter, all right? And surrounding muscles. Now, other than the sphincters that keep the urine inside, we also have supporting muscles from the pelvic diaphragm, the urogenital diaphragm. بمنتهى البساطة, so you do not confuse yourself right now. Do you know the diaphragm that's in your chest cavity? We know the diaphragm, صح? This big dome-shaped muscle that's under the lungs. We're going to imagine these are the lungs. Here's the heart, right? Lungs. So this diaphragm, what does it do? It separates the chest cavity from the abdominal cavity, صح? The urogenital diaphragm is the exact same concept. It's a muscle that separates the the abdominal aspect from the pelvic aspect. Assalamu alaikum. That's it. So the urogenital diaphragm, this is a muscle. So that's one of the external muscles that helps. And this muscle right here, you can see a very beautiful muscle called levator ani. And it's also one of the pelvic floor muscles that aid in the ability to keep urine in and squeeze it in, okay? What else do we talk about? The differences طبعا between the female and male urethra. I'm going to start with the female urethra. طبعا here we don't have a prostate, أكيد. The female urethra is considerably shorter and it is very close to the perineum. The perineum is the area between the vaginal opening and the anus. Basically, it's me saying, because the female urethra is very close to the other openings, like the fecal opening, it is much easier for females to get UTIs. In fact, it's not unheard of. It's very common for a female to present with UTI because there can be very easy cross-contamination. On the other hand, the males they don't have this problem. It's the exact opposite because their urethra is very long and it's also outside of the body, that it has a very, very low chance of being cross-contaminated with other openings, which is why if a male ever presents with a UTI, that's actually a red flag for doctors because it's very, very rare for a male to present with a UTI. Okay? So yeah, so we have the two sphincters, we have supporting muscles, look at that, levator ani, we have the urogenital diaphragm, we have two sphincters, internal sphincter at the bladder neck, and then the external sphincter before the urethra, right? Oh, this is actually, the entire thing is the urethra. Also, another thing about the male urethra is that there are many points. So the urethra that goes through the prostate is called the prostatic urethra. The urethra that goes through this urogenital diaphragm is called the membranous urethra. And then the longest aspect is called the penile urethra because it goes through the penis. All right, so that's also another difference between female and male urethras. I believe that's it. Let's look at this homeostatic imbalance. Okay, renal calculi. Calculi means stones. So we're talking about renal stones. Renal stones usually occur because there is an excess of something like calcium, like magnesium, or uric acid. Precipitation of these substances can cause stones. Why can they precipitate? Could be due to multiple reasons. Could be due to an increase of these substances in the blood, like hypercalcemia, or it could be that they're not being excreted, so they kind of precipitate in the kidneys or in the ureters, and then they form a stone, which are very, very painful. And something that I want you to remember here is how the pain is described. Flank to abdomen pain. Why am I saying flank? يعني if you put your hands هيك on your waists, here, up here, like on the sides, this is called your flank. So if a question ever shows you that there is pain from the flank down to the abdomen and it keeps moving down, this is because the stone causes pain as it keeps moving. But as we said, the ureters are muscular and they move, like they cause peristaltic movement. But it will try to excrete this or push the stone out. And when it does so, and the stone moves during or through this ureter, it causes extreme pain. And طبعا the patient will tell you that the pain is moving from up here to down. So that's a characteristic pain to remember يعني. Kidneys, in the kidneys, if the stone is in the kidneys, it's called nephrolithiasis. And if it's in the ureters, it's called urethrolethiasis. And the treatment is lithotripsy, which is basically breaking up the stones. Causes could be obesity, hypercalcemia, and to prevent it, طبعا, have proper hydration. Because if there's proper hydration and proper flushing of the system, then they will not precipitate, okay? And UTIs, very common in women. We just said this, okay? Very common in women. Some of the causes could be sexual activity, spermicides, and catheters is a very, 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 very important cause of UTIs. Because remember, whenever you introduce something foreign to the body, you're bringing something foreign with it, and it can definitely cause infections, okay? طبعا, an infection of the bladder is called cystitis, and for this, remember something called FUD, frequency, urgency, and dysuria. If you see these symptoms in a question like, a woman, 25-year-old woman recently married or whatever, has been complaining of burning urination or painful urination, that's what dysuria is. Dysuria is pain while urinating. Urgency means the feeling, she has increased sensation of wanting to go to the bathroom, and frequency is she actually goes, like the number of times, let me write the number of times like this, increases, okay? So these are classic symptoms of a UTI. Pyelonephritis is infection of the kidney, and this is very serious, and kidney and the renal pelvis. And here, very important that you see very high fever and back pain. UTIs can also present with fever, but it will not be as high as pyelonephritis. So fever and back pain, sweats, it's really, really يعني, very, very emergent for the patient, for the person. And طبعا, since this is an infection, then we just give antibiotics, okay? Nothing not the treatment is not something special here. Micturition. This is the last aspect of our lessons. And micturition, I want you to keep these three things in mind to make this concept as simple as possible. For micturition to happen, three things must occur. One is that the detrusor must contract, because this is the bladder muscle, right? Before the bladder not contracting, that means I'm not أصلاً going to excrete urine. The second is the sphincter has to open. أول واحد mean internal urethral sphincter. We go up here. This sphincter has to open, okay? So that's the second term. And the third term is the external urethral sphincter must open. So what do I have to do? The muscle has to contract, and the two sphincters must open. لنرى مع بعض what happens. Again, diagrams in Bio 2 are actually very helpful if you break them down and actually simplify the concept. Let's go one by one, okay? Okay, and we're going to start with babies, and I'm going to tell you why. Babies do not have developed higher centers of the brain yet. Hatta we know this because we give them diapers, because they can't control when they go to the bathroom, okay? But we're going to go, because they can't control how they when they go to the bathroom, we're going to start with them because it's simple as ABC. إيه اللي بيحصل? Urinary bladder fills with urine. طبيعي, right? That's what normally is supposed to happen. As it fills with urine, it starts to stretch. This stretching is a stimulus. For what? طبعا this means إنه والله the bladder is filling with urine. But what does it have to do? It tells, okay, madam, the bladder is filling with urine, then I have to tell the spine. Afferent impulses from these stretch receptors go to the spine. Spinal cord. And this is called the simple spinal reflex. Why is it called simple? Because, well, I'll tell you why at the end, okay? Like after I finish with this part, I'll tell you why it's called the simple spinal reflex. Urinary bladder fills, it stretches the bladder wall. This stretching sends impulses to the spinal cord. What does the spinal cord do? It's gonna do three things. We need three things for it to happen. We need the detrusor to contract, we need the internal sphincter to open, and we need the external sphincter to open. How can I do that? And here is the money shot, okay? This is very important. The parasympathetic system is responsible for urination. The way you can remember this is, since the sympathetic system is usually associated with fight or flight and being chased by a bear, remember, if you're being chased by a bear, your bathroom is the least of your worries right now, right? What controls urination is the parasympathetic, which is usually associated with resting and doing things at your own pace and all that amazing stuff. Increased parasympathetic activity is gonna do the first two steps. The detrusor will contract and the internal urethral sphincter will open. حلو. Does that mean I'm done? No. You know why? Because let me go with you back here. طيب, this contracted, حبيت, and this opened, جميل. طيب, what about this? Where's the external urethral sphincter? What about this? طب, okay, the urine's gonna go here, but it's still not gonna pass. We need the three things to happen. And what's responsible for this is the somatic motor nerve. Why? Because the muscles in the external urethral sphincter are skeletal, but the muscles in the internal ones are smooth. So they are innervated by different aspects of the nervous system. Smooth muscle here is responsible, it's controlled by the parasympathetic or sympathetic. Skeletal by somatic. So what's going to happen is, again, parasympathetic activity will increase, sympathetic command must decrease, so I have to go against each other, and somatic nerve activity must decrease. Remember, I have to decrease the nerve activity for it to relax and open. And thus, I have completed my three terms and micturition occurs. يبقى تاني. طبعا this is why it's called the simple spinal reflex, because it's simple as my bladder filled, my nervous system responded, and micturition happened. No special cases here. Again, the bladder, it's a muscular structure, but it's going to fill with urine, it's going to stretch. When the stretch occurs, afferent nerve impulses, afferent away, right? Because it's going from the bladder away to the spine, down. But it goes to the spine, it tells it, hey, الحق, my bladder is now full. But the spinal cord says, okay, since this is a baby, again, they don't control when they go, okay, خلاص, my bladder is full, then I'm going to have to go and urinate. What's going to happen? Parasympathetic activity increases and sympathetic activity decreases. This makes the detrusor muscle contract and the internal urethral sphincter to open. And again, remember, parasympathetic is the chill one, and sympathetic is associated with fight or flight and being not in the position to go and urinate, basically. And then somatic will decrease so that the external urethral sphincter opens, and then we have micturition. Simple enough. This is what the simple spinal reflex is. Simple as the bladder filled with urine and it excreted it out through changes in the parasympathetic, sympathetic, and somatic nerves or like systems. Okay? طيب. We don't stay babies forever. We turn into toddlers and adults. And طبعا as the baby grows older, higher brain centers get activated. We have a new player in the game. طيب. We're gonna take it in the same way. This situation, we're gonna say, no, the person decides to urinate. Again, same thing. We're gonna start with the same thing. The urinary bladder fills with urine. It stretches out the bladder. It sends signals to the spinal cord through the simple spinal reflex. Okay? But when this happens, when this afferent impulses go, they don't only go to the spinal cord anymore. They take also a cute little trip to the brain. ليه? Now, since we are older and طبعا we can't go to the bathroom whenever we want, the higher brain centers decide, am I in a situation to go to the bathroom? مثلا, am I talking with someone? Do I have a bathroom near me? Wallahi, the situation permits. Then we have this new center, the pontine micturition center. And pontine is because these centers, both of these, are in the pons. You guys took CNS. The pons is responsible for this. In the event that I can go and urinate, the pontine micturition center will activate and it will promote micturition by acting on all three spinal efferents. فأنا حرفيا, the only thing I added here is I have extra stimulation على these three things. أنا already, my simple spinal reflex does these things to contract the detrusor, open the sphincters. This just كمان increases that. So that, yeah, sure, 100% go to the bathroom, خلاص, I'm in a situation where I can go. But all it does is it promotes micturition by acting on all three spinal efferents. تاني, what are the three spinal efferents? parasympathetic activity, sympathetic activity, and somatic motor activity. The parasympathetic and sympathetic are responsible for 2 out of the 3 criteria, which is the detrusor muscle and the internal urethral sphincter. The parasympathetic must win for the detrusor to contract and the internal sphincter to relax. And the somatic motor nerve must chill a bit for the external urethral sphincter to open, and thus micturition occurs. Simple enough? Now we move on to our last case, which is inhibition. So it's basically, I'm telling you here, the case in which I cannot go to the toilet. Wallahi, I'm talking to someone, there aren't toilets around, I'm in a car, I'm in a bus. But as we are conscious human beings and old enough where our higher brain centers can inhibit this, that's what happens. Again, bladder fills with urine, it stretches, this sends impulses, and since we are talking about toddlers and adults, then not only will the impulses go to the spinal cord, they will also go to the higher brain centers, and it will ask, is it okay? We are talking about the fact when it is not okay. So it is not appropriate. So what's going to happen? The pontine storage center inhibits micturition by what? By cancelling out these 3 things. حرفيا, this is all it did. مش أنا قلت إن the parasympathetic activity, we said it's chill, they can go to the bathroom. What's going to happen? It's going to decrease this. And it's going to increase the 2 S's. See? So it stops micturition by increasing the 2 S's. You can remember it this way. يعني. What are the 2 S's? Sympathetic activity and somatic motor nerve activity. What's this going to do? Decreasing parasympathetic activity and increasing sympathetic activity is going to cause the detrusor muscle to relax instead of contract, and it's going to cause the internal urethral sphincter to stay closed. Same thing here, external will stay closed. فحرفيا هو بيجي وبيقول no thank you, I don't need any of this, I'm going to go exactly opposite to it, and thus it inhibits urination. Again, let's revise. طبعا now, see what I did is I took this diagram little by little, exposing parts of it. For now, we can go through it one by one. Again, let's start with the simplest of the human beings, the babies, which cannot decide if they can go to the bathroom or not. They just go. For what happens? The urinary bladder fills with urine. It stretches the bladder wall. Impulses go from the bladder to the spinal cord through the simple spinal reflex, and it will do all the things to satisfy our 3 criteria. It will increase parasympathetic activity and decrease sympathetic activity to cause the detrusor to contract and the internal urethral sphincter to open. And it will decrease somatic motor nerve activity to cause the external urethral sphincter to open. And thus I have satisfied my 3 criteria. Micturition occurs. Let's talk about toddlers. We're going to involve the higher brain centers now. Let's say, okay, the urinary bladder will stretch with urine. It will give me impulses, but this time not only will it go to the spinal cord, it will go to the brain. If the situation permits that it is appropriate to urinate, then the pontine micturition center, it's called micturition center, it will promote micturition by acting on these 3 elements, just like the spinal reflex, and thus my 3 criteria are met and the micturition occurs. Let's say I am in a situation where I cannot go to the bathroom, urination is inappropriate, then the impulses that go to the brain will activate the pontine storage center. See, it's going to tell you, la, I'm going to store my urine for now. And what's going to happen is that it inhibits micturition by cancelling these 3 criteria, and thus no micturition occurs. Thus, I hope I made it simple. I repeated it a lot so that it sticks. Then we have, I think this is our last homeostatic imbalance. Yep. Yeah. So, طبعا, you see these three things, all of them could go wrong, which is when we get our homeostatic imbalance. You either have urinary incontinence, which means the person cannot control the urine, or urinary retention. So here, they cannot stop urinating. It's not under their control. وهنا they cannot urinate. عكس بعض يعني. So incontinence could be due to many things. صح؟ فlet's مثلا go to these 3 criteria تاني. What could it be due to? I need the detrusor to contract or micturition. It could be due to detrusor muscle paralysis for whatever reason. I need the internal urethral sphincter to open. For example, the sphincter is not opening due to a nerve issue. Or العكس, the muscles around it are weak, that it's keeping it open. Well, the same thing goes for the external urethral sphincter. You can go at the causes here. Weak pelvic muscles, which can be after surgery or childbirth. طبعا, this is known in pregnant women after they give birth. It takes time for them to be able to control their urinary continence again. And طبعا, it takes exercises. There are pelvic floor exercises to help. Another kind of urinary continence is called stress incontinence. And think of anything that increases intra-abdominal pressure. Pregnancy is one of them. Laughing is one of them. Sneezing is one of them. Anything that increases intra-abdominal pressure is stress incontinence. And then overflow incontinence is when the bladder keeps getting in urine until it overfills and it dribbles. Why am I saying this? أصلا the bladder أهي. حتى if there is a problem, for example, with the sphincters, the bladder will keep accumulating urine until it reaches a specific threshold. After this threshold, it has to urinate. It overfills and dribbles of urine. And then urinary retention is the exact opposite. Could be due to post-anesthesia or BPH. BPH is what called benign prostatic hyperplasia. See the prostate here? When it gets bigger, it's called benign prostatic hyperplasia, okay? And this طبعا causes urinary retention because it presses on the prostatic urethra and thus it makes it harder for urine to leave. And here a catheter is needed. This is an emergency, by the way. If someone cannot urinate for a long amount of time and it starts to be painful, it's an emergency and they have to go to the emergency room to get the urine drained على طول, okay? So for the very, very last time, I'm very sorry لو زهقتوا مني, but this concept is very important because questions will come from it. Okay, this is why I'm stressing on it a lot. So let's go. What happens when the bladder fills? Stretch receptors get activated. What happens when the stretch receptors get activated? They send afferent impulses. Where do they send them? To the spinal cord, simple spinal reflex, and the brain. What happens in the spine? Parasympathetic activity increases. Sympathetic and somatic decrease in anticipation or urination. In a baby, the muscle will contract and the sphincter will open. Both sphincter will open and relax. Thus, urination occurs. In children, the signal will reach the brain. Is it appropriate to urinate ولا لا? If it is, then the pontine micturition center will activate. If not, then it's the storage center will activate and micturition will be inhibited. All right, let's go through our questions one by one. And these are very easy. You can try to pause the video and see if you get the answer correct. Okay, so first up, a woman suffers from urinary tract infection. Lead tends to be in a specific region. Which anatomical region do infections tend to persist in? It's C, the trigone, and we talked about this, okay? Peristalsis. Sorry about that, let's continue. Peristalsis and the propelling of urine in the ureter is by which nerves? That would be B, parasympathetic. Remember, anything related to urination or it's going to contribute to urination, it's going to be parasympathetic, okay? Question 3. A 55-year-old woman diagnosed with hyperparathyroidism recently presented with flank pain that moves down to the abdomen. Upon investigation, she was found to have renal stones. What could have been the cause? That would be hypercalcemia. It makes sense with her diagnosis of hyperparathyroidism. We have a little bit of an endocrine crossover here. Okay. Question 4. A 3-year-old boy started to gain control of urinating. Which of the following neural developments happened? B طبعا, right? Centers of the brain. Okay. He already has the urethral sphincter, already has the afferent impulses, and already has maturation of the detrusor. This is the only thing that changes when they grow older. Matching. Matching is incredible, صراحة. Especially this matching question. Yeah, take a moment. Okay? You can pause the video right here. Okay, so واحدة. Let's go through it one by one. External urethral contraction. أصلاً there is only one thing I mentioned about the external urethral sphincter, and that's somatic. Why? Because remember, it has skeletal muscle, but it's related to the somatic motor nerve. Detrusor contraction. Detrusor and internal are both related to parasympathetic, but here it's talking about what? Contraction. Read the question very carefully. Contraction يعني parasympathetic stimulation. External urethral relaxation. برضو it's related to the somatic motor nerve, بس إيه اللي هيفرق? What's going to be the difference? Here, it's gonna be like relaxation. Sorry about that. Relaxation happens during urination, and here عكس كده, it does not happen during urination. Usually it's closed, right? Okay. Finally, the internal urethral contraction. Again, pay attention very carefully. أنا again خليني أراجع. Usually I need the internal urethral sphincter to be open for me to urinate. So when I say the internal urethral contraction, it's related to sympathetic activity. So again, continuing this question, remember when you're having a matching question like this, or if you have it, remember to read which aspect of the urinary bladder, or of the urethra and bladder are they talking about, and are they talking about relaxation or contraction? Remember our 3 criteria for urination to occur: that the trooser must contract and the 2 sphincters must be relaxed. For anything against that, it's against what they're associated with. Okay? All right. Question 6. 52-year-old man recently came in with complaints of urination. He talks about straining to urinate, not being able to urinate fully, and he never feels like he can completely empty his bladder. Upon rectal exam, an enlarged prostate was felt. Which structure will be obstructed? طبعا prostatic urethra, right? مالناش دعوة بالsphincter. Membranous urethra is not related to the prostate, and the bladder neck is above it. It's not gonna it's not gonna obstruct it more than it will obstruct the prostatic urethra itself. Okay. Question 7. During laughing and coughing and pregnancy, what type of incontinence could be happening here? Very, very easy. Stress incontinence, because all of these increase abdominal pressure. Okay. Which of the following compounds determine GFR? Our trusty Hufflepuff. Inulin. Don't confuse it with insulin. Fun fact: when I first read this chapter when I was foundation, when I read the word inulin, I was like, oh, they misspelled insulin. But it's not. They're 2 completely different structures. Inulin. Also, be careful if a question like this comes, because they can tell you what is usually used to measure GFR in hospitals, right? In blood tests. This would be creatinine. Okay? لكن hypothetically, it's inulin, right? This is like the perfect compound, but we don't use it a lot, as I said, because it's impractical. Okay, let's do question 9. A woman presents with frequent UTIs, loss of bladder control, and increased urinary frequency. So here, I'm going to be looking for a problem that gives me poor bladder emptying, incontinence, and frequency. Let's go one by one. Decreased sympathetic control of the internal sphincter. Let's recap. What's the option? What's the function of the internal sphincter? Is it keeps it closed during storage of the urine. Loss of this, that means the internal sphincter will stay relaxed, but it won't cause incomplete emptying. It will cause stress or urge incontinence, but it won't cause incomplete emptying, and it wouldn't cause frequency issues. It's just going to be no, they can't keep urine in as good, but it's not مش to the extent that it's being described here. Because look, it says loss of bladder control and frequent UTIs. Frequent UTIs there is urinary stasis. What do I mean? Urine is not moving, and when the urine is not moving, infections يقولوا لك السلام عليكم. السلام عليكم they say hello مش bye bye. If the urine is in a stasis, it does not move, this increases the risk for infection. But this takes out A. B. Loss of voluntary external sphincter control. Let's recap. What do we do with external sphincter? We voluntarily hold it to keep the urine in. Its loss, again, will not cause these symptoms. It will cause urge or stress incontinence, but it does not explain the UTIs because the bladder will still empty, and it does not increase the frequency. طب نكمل. So it's not B. Reduced ability for the bladder to contract. That means there is a weak detrusor muscle. That means there is incomplete emptying. The urine stays, في UTIs. Okay. But this usually leads to retention and overflow incontinence. مش what's being mentioned here. And it would decrease frequency. Again, because the detrusor is not contracting, I'm not urinating as much. It would not increase frequency, and it will not cause incontinence بالمعنى that's in the question. That leaves D. Damage to the sacral parasympathetic nerves. What is this going to do? what am I losing here? Or sorry, يعني, what does it control? It controls the detrusor contraction, it controls bladder sensation, and the external sphincter reflexes. So if this is gone, I'm gonna have poor detrusor contraction, I'm gonna have incomplete emptying, I'm gonna have UTIs. Check. If I lose the sphincter reflex, I'm gonna have incontinence. Check. And uncoordinated bladder reflexes increase frequency طبعا. Check. This explains all three symptoms. That basically this woman has damage to her sacral parasympathetics. Her bladder is retaining urine, that's causing her frequent infections, and that's causing her frequent UTIs. And طبعا because she is having increased frequency, she's gonna go to the bathroom a lot because there is uncoordination between the sphincter and the detrusor muscle. Because again, if I lose the sacral parasympathetics, then I'm losing the sphincter reflex. So it's gonna cause incontinence. The sphincter is gonna always be open. Okay? So yeah, it's kind of like the bladder is not contracting well. It's keeping a certain amount of urine in, but at the same time, I have an open sphincter. Urine keeps dribbling out. This uncoordination gives us our increased frequency. Okay? And now, final question is, a 35-year-old man falls from a height while working at a construction site and lands on his lower back. Imaging shows a crushed sacrum. After the injury, he is unable to urinate and has bladder distension. Unable to urinate. Where is it? And has bladder distension. Which part of the micturition reflex is most likely impaired? This would be C. Let's go with it one by one. Voluntary control of the external sphincter. Its original job is you can squeeze the sphincter to hold in urine. If it is lost, then you'll get incontinence. مش retention. هنا he's talking about retention. A is not correct. B. Sympathetic control of the internal sphincter. The internal sphincter is tight during storage mode. If I have impairment in the structure, then again I'm gonna get incontinence, مش retention. It's not B. We're gonna skip C because we know it's correct. Let's go to D. Sensory awareness of bladder filling. Its job is to send stretch signals from the bladder to the brain and the spinal cord when it fills. If it is lost, you would not feel when your bladder is full and might not consciously decide to urinate, but the bladder can still reflexively empty if the detrusor activation pathway is intact. But the most important thing here was C. Parasympathetic activation of the detrusor muscle. Because if this is lost, the bladder cannot contract, urine will build up, the bladder will distend and no urination will happen. Okay? I believe that is it. Thank you very much for listening. I hope inshallah your exam goes well. I do recommend studying renal and looking for questions in books because they do love to get questions from this chapter in the end of the final. This has been Shurooq AlShawaf. Assalamu alaikum wa rahmatullahi wa barakatuh.